And now I invite Ajay, who I'm sure is going to put things in perspective.
Abhimanyu is a little bit, that's a tough one for him. I don't think he had the wheel when he came up here. But, I think it is commendable that, at an interventional meeting a surgeon discusses it, and I think the evidence that he showed is quite compelling. I have no conflicts of interest other than the fact that I'm an interventional cardiologist. I want to start off by saying that this whole debate of the surgeons versus the interventionalists is honestly a debate that I think is started by the surgeons. And this isn't a depiction from the Star Wars movies of PCI versus CABG or the interventionalists versus the surgeons. But I would like to stop for a second and think that this is not the real fight. The real fight is that I think people who are proposing medical therapy are actually trying to blow up the ship. And this is very, very important for our surgical colleagues to realize, and that all the attacks against PCI, I think, currently are a little bit misguided, because I think what's very important is for us and the surgeons together to fight against people who are essentially trying to trash revascularization as a whole. So this was done recently in the the Archives of Internal Medicine, and I'll just read the quote, and this is based upon an article about stenting. And Bill Bowden, who, as you know, presented the COURAGE trial, actually states that we have abundant scientific evidence to support a more selective, measured, and balanced approach to the initial management of stable ischemic heart disease, and one that promotes and embraces optimal medical therapy for the majority of patients as a proven alternative towards revascularization. And so the surgeons should realize that the fight is not so much with us, but we need to band together, because this is something that is going to affect both our lives as well as their lives. And just to think that surgery is immune to this would be short-sighted, because a similar editorial approximately a year ago by Jim Fang in the New England Journal, actually looking at patients for whom most surgeons would say it's incontrovertible that surgery benefits, those with ischemic LV dysfunction, Jim Fang writes, with the results of the STITCH trial, we should be comfortable with the notion that in general surgery is not superior to optimal medical therapy for ischemic LV dysfunction. This is a major issue, and I think we all need to address these types of opinions very proactively. So I will start by actually agreeing with the data presented by the prior speaker, in that I think that the studies of CABG, specifically for multivessel disease, really offer some of the most compelling evidence in favor of the revascularization hypothesis. And by revascularization hypothesis, I mean the fact that when you have ischemic disease, if you revascularize patients, you can improve outcomes both related to symptoms as well as to prognosis. And the key question, as proposed by our prior speaker, is whether we can extrapolate the surgical data to PCI. And that's the sort of crux of the debate. I would posit that yes, in terms of symptomatic benefit, you can extrapolate the data. And so I'll show you some evidence. This is from Berry 2D. This is a trial randomizing patients with multivessel disease or supposed multivessel disease to revascularization versus medical therapy. And in this trial, it was clearly observed that the incidence of new angina, also for patients with angina, the severity of their angina, was decreased with revascularization as a whole, pooling the CABG and PCI arms compared to medical therapy. Now, PCI alone has been clearly demonstrated to reduce symptoms compared to medical therapy across numerous trials, and these are trials in which patients did not necessarily even have multivessel disease. Well, how do we compare relative to CABG? Well, we have a randomized comparison, the Syntax trial. Recall, in Syntax, there were a lot of patients that did not get complete revascularization, even more so in the PCI versus the CABG arm. And yet, if you look at the number of patients that are angina-free in this trial, while at 1 year there's a non-statistical significant difference in PCI versus CABG, slightly favoring CABG, overall PCI did very well and comparable despite a lack of complete revascularization and a lower degree of such in this trial. So PCI does quite well. And in fact, if you look at how patients rate their quality of life, independent from angina, there's very clear similarities at both 6 months and 12 months with PCI compared to CABG, and because PCI is less invasive, the patients that got PCI actually felt better at a month because they didn't have a sternotomy. So I think in terms of symptom relief, as long as we can revascularize the same territories, and that's a key if, then we do very well with respect to symptom relief. The other question comes with prognostic significance. Can we replicate the results of CABG in terms of prognostic benefit to our patients? And this is where the surgeons will argue most vehemently that there's clear data for surgery, but there's not good data for PCI. But forgetting the type of procedure that's done, I think what's critical is what the extent of disease is and how much we can actually revascularize. And I would say that at present we can posit that we can probably do as well if we can revascularize the same amount as the surgeons can. So this is data from the MASS-2 trial, a randomized trial of PCI medical therapy and CABG. We have 10-year follow-up, and these were patients with a lot of proximal LAD involvement. And what's interesting is that PCI was, although not as good as surgery, was better than medical therapy. And this is a prognostic study. And so there is data, contrary to what the guidelines committees and other people write, there is data demonstrating that PCI can improve prognosis for patients with extensive multivessel disease. Now, Berry 2D was a trial that looked at patients with multivessel disease or supposed multivessel disease and looked at revascularization versus medical therapy. On the left of the slide is the PCI arm, and the surgeons are quick to point out that in Berry 2D there was no difference between PCI and medical therapy. But on the right of the slide, which is surgery versus medical therapy, there was a benefit of surgery. So here, this is evidence that surgery is better than PCI. And I would say that's not true because the operators and the clinicians had the ability to decide who needed one versus the other. And for more extensive disease, they actually favored surgery. If you look at the patients that were actually enrolled in Berry 2D, what's really striking is that only 20% of patients who went for CABG had proximal LAD involvement. And in the PCI arm, it was half that. So this clearly demonstrates, and if you look at the number of diseased vessels, the number of lesions treated, that patients with more complex disease were referred for surgery, less complex disease were referred for PCI. And so it's not that there's inherent differences between one procedure versus another, it's just that there are inherent differences in who was treated with one versus another, and the benefit was confined to patients with more significant disease. This has been demonstrated in the whole ischemia hypothesis. If you look at this slide from the Cedars-Sinai database, the more ischemia you have, the worse your prognosis is. And if you revascularize patients with more severe ischemia, as shown in the blue bars here in the slide, you actually can improve prognosis. So again, while I think that the key findings that many people sort of point out is that CABG is more beneficial than PCI, what it really is that if you revascularize more significant disease or more extensive disease, those are the patients who can benefit prognostically. And even in the lower risk patients that were enrolled in the COURAGE trial, shown here in the slide, in which there was only PCI done, if you reduced ischemia in COURAGE, you had a lower rate of death or myocardial infarction. So this is data that I think we need to see corroborated by the actual ischemia trial that's going to be conducted. So I think that for me, all this data regarding revascularization in multivessel disease is reassuring for those of us who perform PCI because we know we can improve symptoms and we think we can improve prognosis. But ultimately, what it comes down to is which of the two do you prefer? And so I'll try to show you a variety of reasons why I would prefer PCI. First, though, I'll say I do like CABG, and I think CABG is the gold standard for the treatment of multivessel disease. I would agree with our prior speaker on that, and the reason I like it is because it's one-stop shopping. You can do a single procedure, it generally tends to last. If you have complete or difficult revascularization, provided your distal targets are good, CABG can be great in those patients. If somebody has 3 chronic total occlusions, I know I'm not going to do as well as bypass if the targets are good. Compliance and adherence are less of an issue with CABG, and provided the patient's not frail, I'm very good at risk assessment using a number of risk calculators that are out there. And then again, surgical data supports the revascularization hypothesis, so I can confidently state to my patient that I can improve their prognosis by doing a CABG. That having been said, I grant our prior speaker all these facts, I still prefer PCI for a number of patients, and I'll go through the reasons why. This issue of it being less invasive is critical because ultimately there are many patients who would prefer a procedure that has slightly greater mortality over the long term to avoid this. Because the alternative to this, the sternotomy, is this, which is a radial done PCI. And so if you ask a patient, and I have this conversation with patients frequently when I take them off the table after diagnostic catheterization, I say, listen, surgery may have a better mortality over the long run than PCI, and they still prefer the less invasive approach. And this is something that many guidelines committees and people who are making decisions completely forget, and that is that patients have a choice in this, and most patients will prefer a less invasive approach. We need to figure out how to make the less invasive approach better. So what's the downside of doing PCI? Well, it's largely related to repeat revascularization procedures. Our surgeons are quick to point out that when patients have PCI, they have to come back, and that's a big problem, and everything else. Well, looking at the actual data, surgery versus PCI, this is in the bare metal stent era. Clearly no difference in mortality over the 5-year follow-up with PCI compared to medical therapy. And this is from Syntax, where you can see at 4 years a doubling of the rate of repeat revascularization. But it's not so much the doubling that counts. What actually counts from Syntax in particular is the absolute risk reduction. The reason the absolute risk reduction in this case of about 11% is important is because that impacts the number of patients you need to treat in order to affect the outcome. What I mean by that is based upon Syntax, at 4 years, if you treat 10 patients with CABG or 9 patients with CABG, you will prevent 1 repeat revascularization with PCI. When I present that data to a patient, that's a very small price to pay, particularly because repeat revascularization with PCI is typically done by another PCI rather than surgery. And if they need surgery, provided I haven't stented across a bypass anastomotic site, they can always have bypass later. So people are quick to point out, however, that the death rates in Syntax may be different, particularly over the long-term follow-up period. But as I mentioned to you, if you look at particularly out to 3 years and even 4 years, the overall rates of death, stroke, and MI are quite similar, and there are problems with the stents that were used in this trial. Again, because it's less invasive, there are patients who would prefer to have a less invasive procedure with perhaps even a mortality disadvantage over a more invasive one because they don't want their chest cut open. Now, what about this issue of the stents not being bad? And so we're going to see the stents not being good. We're going to see Freedom presented later this year, and the whole debate's going to come up again, and I guarantee you that the results of Freedom are going to support surgery versus PCI just based upon what I know of the enrollment criteria and the types of stents that are used. But I will tell you that the results of Syntax and Freedom absolutely don't apply to current clinical practice. And one of the reasons why is just take a look at this slide looking at all-cause death to 12 months from Syntax. Do you think in your practice that there is a higher mortality at 30 days with drug-eluting stenting compared to bypass surgery? No, and the reason we know this is that's why we do less invasive procedures. So there was something clearly wrong in the Syntax trial that led to a higher mortality at 30 days with stenting compared to surgery. So any long-term comparison of mortality data from this trial is going to be skewed by the fact that there was something wrong with the way people were doing PCI, because we should not be bumping off patients at 30 days compared to surgery. So that's from one aspect. The second aspect of Syntax relates to the issue of the stent thrombosis rates. 8.8% stent thrombosis total over 4 years is completely unacceptable and actually is outside the scope of what most people see nowadays. This is partly because they enrolled super complex patients in Syntax, but also because they used a stent, which we don't pretty much use anymore. So if you look at data from the Xience V experience, we have much lower rates of stent thrombosis with these newer stents. Most people don't use Taxus stents anymore. And additionally, we have lower rates of ischemic target lesion revascularization with these stents compared to the Taxus stent that was used in Syntax. If you were to hypothesize, and again, I admit to the prior speaker that this is a hypothesis, but if you were going to hypothesize that we do real-world practice with the Xience V stent or a stent similar to that, and were to extrapolate the results to Syntax, we actually come out at relatively equivalent terms to surgery. So again, I think that not only is Syntax not applicable based upon the stenting and how it was done, but clearly Freedom is not going to be applicable either because it's using a stent that we don't use anymore. As far as the non-randomized data, we heard the prior speaker bring up ASSERT and other trials. I think this data is poorly informative. There's no way you can compare CABG and PCI in a non-randomized way. So this is the data from ASSERT that was presented at the ACC, looking and showing that essentially no matter what kind of statistical adjustment you did, mortality was better with surgery compared to PCI. The problem is that look at the baseline data and who got one therapy versus the other. Every single p-value in this comparison is highly significant and showing you that the patients that got PCI in ASSERT were sicker than those who got CABG. In fact, this is just an example of two patients with identical STS risk scores. The one on the left was the one likely treated with CABG, and the one on the right was the one likely treated with PCI. Independent of the actual therapy themselves, you can predict that the one on the right is going to do worse. And these patients have the same age and predicted risk because the data captured in ASSERT does not capture things like frailty, which can clearly impact outcomes. In fact, in this week's New England Journal of Medicine, the letter that I and others have written has actually been published on the problem with the CERT. And the basic problem is that if you have a confounder such as frailty, which has actually been measured in these databases to increase mortality by a factor of 5, it really would only need to be present in 15% of the ASSERT population to completely negate the results observed in this study. And the fact that they actually were able to publish this data knowing that this confounder existed, in my opinion, which is what I've written to the New England Journal and they thought it suitable to publish, is I think something that should show you that these comparisons should not be made. Now, what about other issues? The prior speaker mentioned cost. I think the cost and risks of PCI are decreasing, not only due to new drug-eluting stents, but also because of the use of something we call optimal functional revascularization. So the famed trial using FFR basically showed that you could reduce the risks of periprocedural MI with PCI by using an FFR-based approach, but more importantly, we could decrease stent utilization. So going from a range of 2.7 stents per patient down to 1.9 stents per patient, which is very important in the cost calculation shown by the prior speaker. And as a result, in the use of FFR in FAME was highly cost effective because it reduced MI and the costs were lower as well. And moreover, you can actually change the categorization of patients. Many of those who have so-called 3-vessel disease based on the angiogram actually don't. They have 2-vessel disease. And many of those who have 2-vessel disease actually have single-vessel disease. So perhaps we're bypassing and stenting vessels that we don't need to treat, and we should only guide things based upon functional ischemia. And I'll end by saying that CABG is not problem-free either. We've heard that it improves survival and other things, but I really wish, and I send people to CABG frequently, but I wish that the sternotomy wouldn't hurt. I wish that nobody would need a transfusion or a take-back or a pericardiocentesis. I really wish that my patients could go home the next day and not have to go to rehabilitation, that there would be no neurocognitive issues related to it, that vein graft disease wasn't that bad, that everybody who needed it was a good candidate for it, and finally that all CABGs, irrespective of the estimable surgeon before me or those that are not as good, everybody could get the same result. So where do we stand in 2012? I think basically both strategies have great outcomes in appropriately selected patients. The hard clinical outcomes are very similar, particularly with the use of newer technologies. And ideally, we need to weigh the risk of potential repeat procedures with PCI versus the greater morbidity of CABG. And ultimately, we need to ask our patients. And most patients are going to prefer a non-invasive approach or a less invasive approach. Thanks so much.
Thank you, Ajay. You have established your option very reasonably. Now, as per tradition of the debate, the first speaker will get 2 minutes for rebuttal. Hemant, would you like to speak for 2 minutes?
Thank you, Mr. Chairman. First of all, I would like to congratulate my colleague speaker. He has put the data in a nice way. He's still saying CABG is better than PCI for triple vessel disease. The buts will always be there. But the polymer stent has come, but the biodegradable stent will come, but the sternotomy is painful. We are discharging in this unit, in the unit I work, we discharge the patients on day 5 and day 6. We are doing minimal access surgeries now. Our left internal mammary rate, we looked at it, is more than 97 to 98%. Bypass surgery stands the test of time. Therefore, please take home the message that in triple vessel disease, consider it. And the other thing is, a cardiologist telling you need bypass surgery is different to a surgeon telling the same patient you need bypass surgery. I don't tell patients that these are the issues about PCI. So similarly, I do not expect the cardiologist to be telling the patients about surgery. So, and I think till that time that surgeons talk to patients about CABG, I think this debate will continue. Thank you.
Sorry, I just want to tell a quick story. So we actually had, one of our cardiology fellows had an uncle who had symptomatic multivessel disease. And what he decided to do in the true iteration of the heart team approach is he asked every cath lab attending and he asked all the cardiac surgeons what they would recommend for this patient. And every interventionalist in this case actually said you could go either way, surgery or PCI, and it was a dealer's choice, the patient's choice. All 5 surgeons recommended bypass surgery. So I think that this issue of equipoise and the heart team approach goes both ways.
Thank you.